It was an excellent webinar, and all the speakers were very good. And I would like to have one comment for each of the presenters. The first one to Selva. Selva, there are a lot of things just coming out saying that when you use harmonic for a myomectomy and then use multiple layer sutures and preservation of the endomyometrial junction is a preventive for rupture uterus. What is your comment on take on it?
I mean, these are what people talk about, but I don't think there is any paper that looked at this as a prevention for prevention of uterine rupture. These are all probably expert opinions on prevention. I think it's logical. What they're saying is logical, but to have a paper to address this is difficult, I think. And I don't think there's any published papers on this particular way of doing the myomectomy and the suturing. But it sounds logical.
Thank you. And my questions to Dr. Raymond. You have seen a lot of patients on infertility being treated with HIFU. There is a lot of publications saying that it does not alter or it does not deteriorate the ovarian reserve. What is your comment and what is your observation in your patients with infertility?
Yeah, look, we don't go near the ovaries, so it's not like embolization where you affect the ovaries. So we make sure that we keep well away from the ovaries, so there's no effect on the ovaries. So it shouldn't interfere with fertility. The problem in our patients is we have the infertility is multifactorial. We have a lot of pelvic inflammatory disease besides the fibroids. So, and we don't do any workup on those patients pre-HIFU. So we're not quite sure of the causes of the infertility, but we have found in those where the fibroids have shrunk that they have conceived. But yeah, there's no effect on the ovaries.
And another question to both the second and third speakers. See, I have done about, say about 2 years of my experience with MRI-focused ultrasound for HIFU with that Insight Tech. Then after that, it is just, we have stopped it. On comparing with that, this ultrasound-focused HIFU has got a lot of advantages. But however, you have to depend on MRI for pre-treatment evaluation, post-treatment evaluation, and then if you are going to establish a center, probably it adds up. Would you be more happier if there is some developments on ultrasound like 3D, 4D, spectroscopic appearances with which you will be done away with the MRI when you are using the HIFU system?
I think Felix can answer that.
Yeah. I think we should work on that. You are right, because MRI is very expensive, and the 3D and also the ultrasound, which use the microbubble and the non-perfusion area under microbubble, we can work out. I mean, hopefully they will be equivalent to that shown by the MRI. I think that's one of the directions of research I'm doing in Hong Kong. So. Hopefully we'll have the answer soon.
Yeah.
Thank you, Chairman. Thank you.
Correct me if I'm wrong, but I understand now in Chongqing HIFU, they already have the software to merge the ultrasound image and the MRI image live as when you're doing the HIFU. So if you are looking forward to set up the new version of HIFU machines, I think it should be in the system already.
Oh, in fact, my system is from Chongqing HIFU, and the MRI incorporated into ultrasound, but there's still some limitation. The software is not completed yet, so it doesn't have auto tracking when the patient move, and also the MRI is really the sagittal view as well as the AP view, and they do not correlate with each other. I'm going to let them know. Hopefully they will improve it. And for the new learner, it will be easier for them under the ultrasound have the MRI image to see where the target point are. So that's important.
Okay, thank you. Pong, do you have any questions?
Yeah, question to Silva.
Yeah.
And for uterine rupture after myomectomy, it is very common that people who have entered into the cavity will require cesarean section. I understand that in your presentation, in one of the paper, they said that that is not a cool feature that require cesarean section. So what is your view on that?
The data that we have, Dr. PM, is that they couldn't pinpoint any factors that precludes that we can say that it is necessary to do a cesarean section. That's what the 19 cases that they studied that had undergone uterine rupture, they had only 5 cases, I think 4 cases that had entered the cavity. The rest is not. So that they couldn't come to a conclusion to say that, okay, if the uterine cavity is entered, you will have to do a cesarean section. Or if you don't enter, you don't have to. But as you can see from the data itself, most people who do laparoscopic myomectomies, the chances of allowing them to have a normal delivery is lesser, far lesser than when you do open myomectomy. They didn't analyze in that particular, the first study, they didn't analyze whether the uterine cavity is entered or not. So I think it is very difficult because they're all retrospective studies, they are all meta-analysis. So it is all comes down to the surgeon's preference, the surgeon's confidence. And I think the general consensus is if you have entered the cavity, then you will probably be very worried to allow the patient to have a vaginal delivery. That's a general consensus. But in the study, they couldn't prove that. I hope you get that.
Yeah, I actually understand that, because why I asked the question is that you said also people are using the entry into cavity as the criteria for doing cesarean section or not, and I doubt very much about why. So I mean, by entering the cavity, from doing a very deep, say, myoma, the only thing is the endometrium. My understanding is that probably the most protective value of the uterus is the uterine wall. So if you do a very deep myomectomy without entering into the cavity, as compared to do a myomectomy with entering the cavity, what will be the difference in terms of the rupture in subsequent pregnancy? I guess there's not much difference. Because I don't think the endometrium will actually protect the uterine rupture. That's my point. So that's why I don't think that entering into the cavity, it should be the crucial factor in determining whether the patient should have cesarean section in subsequent pregnancy. I think that's a very important concept or principle.
Yeah, that is an interesting point. In fact, in the 19 cases that they studied of uterine rupture, there were some that were pedunculated fibroid that had rupture. So there are probably more factors that are involved besides the depth of the entry of the fibroid. But as you know, uterine rupture is a major disaster. Many people just shy away from allowing vaginal delivery when you do say a deep-seated myomectomy. That's a conclusion that we can say from that study.
Okay, gentlemen, this is my take. We are all taught by our great teachers to watch out for the endometrium and not to enter into the endometrium. But frankly, if you want to do proper myomectomy and proper stitching, invariably, many of us are guilty of entering the endometrium. So I tried to look up the literature to see who mentioned this thing about entering the endometrium, and it's a taboo. I could not find any. So it could still be a myth that by entering the endometrium, the whole uterine structure is weakened. Bear in mind, we have done a lot of curettage, DNCs and all this, which has done worse things to the endometrium. And this thing about Whye have to be very careful, because people who propose Whye that was already 20 over years ago. You will take it to current status, better blood, better antibiotics, and of course, very active lawyers around. We have to think twice. More so when our family size is small. You know, we only have 1 child or 2 child. So to take the risk of a ruptured Whye, although the incidence is rare, but when it happens to that particular couple, it's 100% hit. So please bear that in mind. And I'm really, really happy also to learn from South Africa that, you know, you should speak to the women group and the population group of the ministry, that the social status of a woman depends very much on the number of babies you bring forth to the world. And this is one culture I just learned from Raymond. Okay, can I just go around and ask? I know I'm revisiting the last webinar. Can I ask Dr. Yuen Pong, what is your take of morcellation? Do you still do it in the back? Your advice.
Yeah, my advice, I think we should do a morcellation in the back. And actually, I have been doing that since probably end of 2014. I've been using the back. So the reason why is, one is obviously, I mean, there's a preoperative difficulty in diagnosing sarcoma in common fibroid. Although the overall risk people talk about is not very high. But if you based on the best evidence, so-called best evidence from the meta-analysis, which was reported by the ARHQ, I can't remember the full name of it. And it said that among all the fibroid requiring surgery, so the risk of being a sarcoma is talking about 1 in 1,500 to 1 in 2,000. So that is not a very high rate. I mean, it's not. I mean, this again, to me, this is not a very unusual scenario. So anything we can do to try to protect that, I think is reasonable. The second thing is, in the past, we don't do that because we find difficulty in doing it. Because normally we are dealing with big fibroid, large fibroid. We have to use morcellators, knife, scissors to cut around so you will perforate the back. So nobody's doing it because technically it's very difficult, and you require multi-port rather than one single port. Right? So a lot of people are not doing that. Now we have the ways of doing it, not difficult, right? And also we have different beds available to do that. Then we ask ourselves, why not? We try to do everything to try to minimize the risk. Say doing surgery, we try to minimize the risk. Doing morcellation, why don't we minimize the risk? So my view is I do morcellation as far as possible in almost all cases, not only in myomectomy, and even when I remove the uterus through the vagina, I still try to put them in the back.
Sure. Okay, I understand. So what is good about this webinar is we hear from the experts from all over, and the reasons why they want to do something and the reasons why they do not want to do something. So, well, the take-home message is there's no right and wrong. It's which you are comfortable with and which you think is safest for your patient. Coming back, Raymond, do you do the morcellation in the back?
No, I don't do any endoscopy.
Okay, sure. So
and also at our hospital, we've only acquired laparoscopic equipment about 2 years ago. So we're still in the early stages of learning.
Okay, sure. Thank you. What about Felix? What about you? Do you do morcellation in the back?
For very big fibroid now, I do mini laparotomy. Just a 5 centimeter wound, I can remove big fibroid. I mean, sometimes when we do laparoscopic and even the morcerator and all added together, I mean, will be quite big. And sometimes you even use a mini laparotomy to remove after laparoscopic extraction of the fibroid to remove it through mini lap. So instead of saving my time doing laparoscopic and more expense for the patient, I just do a mini lap and it worked well.
Okay, so which means that most of the time you do not need a bag. Am I right?
No, because I use a wound protector and I bring the fibroid really up to the skin. Hong Kong lady is good. They are very thin. So it's quite easy. And also when you macerate the fibroid, inside the inside the center of the fibroid, there's no bleeding at all. So when you gradually move out and hardly there's a lot of blood loss. I mean, yes, there might be 100 and 200 mil blood loss for very large fibroid, up to 10 and 12 centimeter. So I did for some of the very difficult case, and I may use that, especially nowadays, think like more than 12 centimeter, instead of doing it very difficult one, especially the T2. I mean, MRI show is a difficult fibroid sometimes. I may use mini lap.
Okay, sure. Now to Salva, do you master in the back?
Yeah, yeah, sorry. Carry on, Felix.
Yeah. No,
Okay.
I thought, well, for small fibroid, which I can put in the bed, yeah, put in the bed, right? When I use the electric macerator.
Okay, sure. Salva, your take.
Okay, in principle, I would love to do my modulations in the back. I do that for a lot of my patients, but sometimes I get lazy. I must say that. You see a small fibroid and you put in a modulator and you just modulate it without the back. So my thinking is actually my thinking is not more for the cancer part, but for the parasitic fibroids, the spread part. So actually, the bigger fibroids I modulate within the bag. The small little fibroids, I actually don't bother to put in the bag, and I just modulate it out. That's the principle that I'm following. So my thinking is I don't want to, by rotation of the power modulation, I don't want the fibroids to go all over the place. And if I think that fibroid, I can see them properly and I can modulate without it, I just don't bother to put in a bag. So that's the way I'm doing. So the bigger, it's going to take a long time. I would prefer to try and put it in the bag. It's more difficult, but at the end of the surgery, I know that I've got everything out. Whereas a smaller one, I can see everything I modulate. Sometimes I don't waste my time putting in the bag. And I don't use a simple bag like what PM uses. I use the more safe bag, which is actually quite costly to us, to the patient. So that is a principle that I'm following.
PM has got his technique of recycling some of these bags, and maybe one of these webinars you should ask PM to present his technique, his invention of using things that he can recycle around I mean, I am referring to sterile bags. He recycles them. Okay. Okay. Well, let me ask you this question, Salva. How long have you been using the bag? How many years?
For about probably 5 to 6 years. I think I'm the first in Malaysia to start the more safe bag, and I think after that, Bernard has brought it to Singapore. So probably about almost 5 to 6 years when all these controversies have come up. It was a struggle at the beginning to put it inside that more safe bag because that bag has got its own problems as well. But now we have got quite good at it. We could put it in quite easily and do the surgery. But it still takes an extra little bit of time to place the fibroid. The bigger the fibroid, the more difficult. Sometimes the fibroids are large. It doesn't fit into the bag. So I actually have to cut it with a knife into 2 pieces and then put one at a time and then modulate. So it takes a little bit of time. We only have one type, what do you call as pre-prepared bag, which is the Indian more safe bag. PM's technique, he teaches us in the Afghan, it is very, very good. But somehow when I wanted the bag, they can never find it. It's actually a bag that he uses a suction bag. When you take out a suction, that bag, he keeps it, and he does it very nicely. I do it on and off, but sometimes after doing for 3 hours struggling with a fibroid, and then you say, now I've got this fibroid to deal with. You become lazy, and then that's when you start. Even yesterday, I had one fibroid which is about 6 centimeter fibroid. I just mostly without the bag. It is, you have a principle, but you don't follow it. You know what I mean. So that's how I've been doing.
Okay, just to remind, gentlemen, just to remind all of you, you may see that about 100 of us has logged into this channel, but actually there are 1,000 people from China logging in. Please speak slowly. Okay, Dr. Gopinath, what about you? Do you use a bag? I can't hear you. I can't hear you. No, Gopinath, you have to.
I agree with Selva. It happens to be a little bit of a long, tiresome end of the surgery. You don't want to just go back again and then try to do it and do a complete work with probably a wash and then make sure that you have not left behind. But however, it happens to be something like a small, we use a suction bag which has been just taken out, and then the sisters will make a tie around and just use it. We do not follow the regular endo bags.
So do you or do you not on a regular basis?
Yeah. No, not on a regular basis.
Okay. All right. Sure.
Not on a regular basis.
Yeah. It's good to know, because across, different countries and different practices, I would like to know, because that gives everybody, especially younger doctors, of the respect for each and every one of the practices in different countries, and we should not say condemn using the bag, or we must say that we must use the bag. It really depends on the individual. But bearing in mind, all of you great surgeons for the past 20-30 years, ask yourself, how many times have you seen a leiomyosarcoma? In those days, it's not the bag. So sometimes I don't know whether we are doing it because it's fashionable, or because some other countries are doing it and we have just have to toe the line. But again, please go back, think about it. And Selva, you said you want to prevent parasitic fibroids. I agree, but why didn't you think of it way before the leiomyosarcoma? Okay, sure, I'm just tickling you.
Dr. Lee, what is your final verdict on the bag?
Can I make a comment?
In my practice, I don't use a bag. I only use a bag on two occasions. One is the patient's a lawyer. The second one, the patient has read YouTube and asked for it. Apart from that, I will tell the patient, I don't use a bag, because you have to embark on a surgery on you. True to my heart, I think it's 100% not the cancer. Of course, we can miss. You may say I'm just lucky, but I find that when I try to use a bag, it was really like gymnastics to me, trying to feed which one goes to what. And in so doing, it may, in the learning stage, may have more injuries than using the bag. So I must declare, I don't use a bag. And also I believe the moment you cut into the fibroid, if it's cancerous, you would have upstaged the cancer the moment you cut into it. So using the bag, maybe you said the area of spread is limited, but you already have upstaged it. So that's my take. Okay, we are open for Q&A from anybody who is logged in. Anybody has any questions?
Dr. Lee, there is a question here from Dr. Zoraida, a friend of mine from Philippines. I'm looking at the question. It says that, what is the recurrence rate of myoma after HIFU treatment?
I suppose if you are doing it in Africa, then genetically the recurrence rate is higher. But I don't think there's a consensus from Asia of the recurrence. I don't know. So I would say the younger ones, because if you're in the 20s and 30s, you have a myoma, the chances of recurrence probably about 10% or more. But if you have a myoma when you're about mid-40s or 50s, then the recurrence rate is probably low.
I think the host has accidentally muted everybody. I think we should unmute.
Oh, yeah. Okay, again. No.
Sure. Unmute. So anybody can.
Hello. Hello, it's Ala from Jordan.
Yes.
I have question.
Yes.
I have laparoscopic myomectomy on Saturday. She previously treated by HIFU. Is it difficult? Is the surgery? Shall I expect difficult surgery if the patient exposed to HIFU? So the patient treated previously by HIFU, the myoma, treated previously by HIFU, but it did not respond, or she has recurrence after 2 years. So I'm afraid that the surgery will be difficult for inoculation or something.
Okay.
The problem.
Yes.
Can I
Yes.
answer?
Sure.
So the problem after HIFU is that the fibroid becomes all soft. So it's not easy to shell them out. It becomes all mushy, the fibroid, and your plane of cleavage is disturbed. So surgery is a lot more difficult after HIFU.
Okay, thank you. Thank you.
Oh, okay, my take, I have very limited experience of to repeat because I just started.
Thank you.
For the past 2.5 years, but on one occasion when I have to do myomectomy for a HIFU patient after delivery and after HIFU, it's because the pedunculated fibroid fails to shrink at the rate that the patient would like it to be. So I have the advantage because she had a previous Caesar. So I just did a laparotomy and removed the fibroid, which is about 8 centimeters. No worries, because what HIFU did is, I think HIFU is just causing shrinkage and atrophy. And depends on what stage you have to reoperate on the fibroid. Say, I think if it's within the first 3 to 6 months, it may be a bit soft. But anything that is more than 2 years or more, I think most fibroids will undergo a process of fibrosis and calcification. So there again, it will be the same scenario you probably face in a fibroid whom you have treated with GnRH or other modalities. But in your expert hands, I don't think you will have difficulty operating on a fibroid that has undergone or have been treated with HIFU. I don't know what the other experts think. I don't know. Are there any more?
Thank you for the answer. Thank you.
Thank you. Most welcome. Any more questions from? Or there's somebody to say hello to Professor Wong from Philippines, I think, and someone wants a translation lectures. Someone's asked, Professor Felix Wong, how much does HIFU treatment cost in Hong Kong? But this person wants it in US dollars. Any more? No, unmute. Felix, unmute.
Can you hear me?
And now I
got
can.
4 levels of patient payment. Those who doesn't have any insurance, the amount of money is they pay for private in the clinic is around 10,000 US dollar. No insurance. For the one with insurance, and they possibly are paying 15,000 American dollar. So this is the range. So this includes everything, including the surgeon, the anesthetist, and the equipment, the cost of staying in the clinic. I think your price is more expensive in Singapore then.
No, Singapore is a poor country now. No. Hong Kong has always been charging higher than Singapore, so much so some of my colleagues asked me to go over to Hong Kong to work.
No, I mean, Hong Kong sanatorium will charge more for myomectomy.
That's
PM.
That's true. So the king is there, P.M. Yuen is there. He controls. Okay. Jokes aside, can I just ask Felix? can I ask Salva and Raymond, and especially Felix and Salva, and both of you are great laparoscopic surgeons. You believe in the art of laparoscopy. What attracts you to switch or to adopt a new technique called HIFU in your practice? Felix.
Yeah, I changed to HIFU technique because not only I don't want to do laparoscopic, I'm still doing laparoscopic surgery, but I think they give the patient another alternative. And that's what I want to explore. And also I find that this alternative may be more useful in various ways, which I have mentioned. So that's why I'm interested to change over. It's not change over, but now to move to another direction. And while just like in those days when we moved from open surgery, we are quite confident with it, but we moved to minimally invasive surgery, or laparoscopic surgery. And this more or less the idea I have. So that's why I changed over.
Okay. Salva, over to you. You're already so busy, Salva. Why do you have another arm of surgery? What attracts you?
Okay, it took me a long time to go into HIFU. I still haven't started HIFU. The machine is in Malaysia, but because of MCO, we couldn't install the machine yet. I'm quite excited to bring this to Malaysia. Now, basically, I am a fertility specialist. I mean, I have been running IVF services for 22 years, so I'm always looking for better ways to try to help my infertility patients to conceive. So one of the areas that I realize is the borderline fibroids. Now, we get infertility patients with fibroids of 3-4 centimeters, probably type 3, a lot of them maybe type 4, but just, very near the junctional zone, which we don't know what to do. Now, these fibroids, to do surgery on them, it's probably not a good idea. And to do IVF on them and help them to get pregnant, there is enough evidence to say that these fibroids will actually reduce pregnancy rates. In fact, I've written a review article which has been published in GPM, Gynecological and Pelvic Medicine, looking at these type 4 fibroids, small type 4 fibroids, and how to deal with them. And it's clear as at least type 3 and type 4 fibroids, small fibroids, actually reduces pregnancy rates. So I've looked at all the other options, uterine artery embolization, not myomectomy as well, plus SMIA, anything that can help to shrink these fibroids. And HIFU seems to be, probably will be one of the best to do this. And I actually spoke to Professor Wong, and he said that nobody has done any work on this type of small fibroids affecting fertility. So this is the area that I'm going to concentrate on. The type of fibroids that surgeons don't want to operate, but we know that it affects fertility. So this is a good area. Of course, I also want to provide services for this group of patients who are frightened to do operations or multiple. Previously, I've done surgery and then we want to shrink it. Those are the standard, but this is one of the areas that I'm very interested in. And that kind of triggered me, say maybe I should get into HIFU to look at infertility in a different area. Of course, the other big problem even today I saw is this lady who is 35 years old who is suffering severe pain and dysmenorrhea with adenomyosis. With big adenomyosis, that we don't know what to do with them. And I think next meeting will be talking on this. And this is another big area in infertility that all infertility specialists don't know what to do. We can collect the eggs, we can create the embryos, but the uterus is not good enough to implant. So if we can shrink it with HIFU, then they get a very good chance of pregnancy. So these are the two areas I'm looking at.
Thank you. Actually, gentlemen, one of the things I realized while I'm doing HIFU now is we provide those ladies, especially younger ones, to stop the growth of the fibroid so as to retain their fertility and so as to, for the older ladies, not to lose a womb. So actually one of the reasons why I talk about HIFU is I've seen so many times the fibroid grows 1 cm by cm every year until it becomes 10 cm, and somebody says, do a hysterectomy. But what we're trying to do in HIFU is to stop its growth in its track. Okay, Raymond, what attracted you to HIFU?
Well, as I mentioned in my talk, our patients are very resistant to surgery. So as soon as we mention myomectomy, the patients have to sign for hysterectomy in the event of an emergency if we can't stop them bleeding. So they all refuse surgery, and they just keep coming back having bled out, requiring blood transfusions. So for me, this was another alternative treatment for them, which I'm finding is working very well.